should I have done the eye tracing?
Okay, I think everyone sitting in this room will agree that all the premium lenses we put, be it multifocal, be it trifocal, or be the extended depth of vision, they should provide the premium results. Cataract surgery nowadays is not just the simple cataract surgery, it has become a refractive surgery. Patients' demand are sky high, they want more and more of the clarity and the vision. So on a beautiful day, I happened to operate on a 53-year-old man, and we had counseling for everything. As far as the surgical steps are concerned, it was absolutely fine. Capsular axis was round, circular, no problem. And we implanted one of those premium lenses, and it was in the bag. There were no complications. But still, I'll come to know. Patient was absolutely quiet after a week's follow-up, almost emetrop, reading 6 by 8 and N6, but still the patient is unhappy. Patient complained of the blurring of the vision, decreased contrast sensitivity, as well as the glares, halos, and the starbursts. So, being a surgical surgeon's point of view, it was absolutely perfect surgery, but still the patient was unhappy. We went back to the books and tried to search what are the possible reasons for the same. And the answer we came across was the wavefront, and the wavefront analysis. So, one such device is the eye trace, which is developed by the Tracy Technologies, and it's a combination of the ray tracing wavefront and the corneal topography. So, how does it help in our daily routine premium IOL surgeries? First of all, it helps in understanding the optical system alignment. As you can see, for any premium surgery, any premium lens which we are putting, the centration plays the most crucial role. And most importantly, it is basically the center of the capsular bag. We call it the optical axis. It is important to understand what are the angle alpha and the angle kappa. And angle alpha, that is the multifocal IOL confidence metric. So basically, angle alpha is nothing but the distance between the visual axis and the center of the limbus. Here you can see this is the red cross, that is the visual axis, the green cross, that is the center of the pupil, and the blue cross, that is the center of the limbus. So ultimately, angle alpha is the distance between the visual axis and the center of the limbus, while the angle kappa is the visual axis, distance between the visual axis and the center of the pupil. So what are the important values? So lower angle alpha and lower angle kappa, they tell us there whether the patient is a good candidate to put the premium IOLs or no. Their value should be less than 0.5. If the value is more than 0.5, then patient will be unhappy. Another important thing the eye trace does, it gives us a total aberration value. Not only total aberration value, it gives us the corneal as well as the lenticular aberration separately. Here we are removing the lens. This you can see, this is the total eye aberration, this is the internal, that means the lenticular aberrations, and this is the corneal aberrations. For us, for the premium IOL surgery, the corneal aberrations, they play the most crucial role. Lower the corneal aberrations, the patients will have the good chance of the particular good vision. Same thing goes with the point spread of function, that is nothing but the response of the imaging system to the particular source or the particular object. Here, it should not be more scattered like this. Here, this is the total, how the patient is going to see without the lens implantation, and this is after what patient will see, because we are removing the lens, so lenticular part is scrapped out. What we are concerned is again with the cornea's point spread of function. It should be properly like this or a particular point or object, not like this where it is scattered. Another important thing is it gives us the measure of the modular transfer function, which is nothing but the contrast sensitivity measurement. Here again, the cornea's readings are the most crucial one. It has to be more than 40%. So this is the area which is under the curve, this curve. It should be, as it is more, the patient will have the good chance of vision. Also, it has an integrated toric calculator as well as the surgical induced astigmatism analysis tool plus marking tools as well, and helps in the precision of the proper placement. So now you can just guess out what went wrong in my patient. I'll put this map. So these are the wavefront analysis. These are the total eye aberrations. These are the lenticular, and most important for us are the corneal ones. Here you can see this is an extremely high order aberrations. The first thing went wrong in my patient in the high corneal aberrations. Second thing, as I told you, the point spread function, it has to be particularly focused on a particular source or point, not a scattered one. So here you can see patient again had this corneal point spread function very poor. It is a scattered one. Third thing, which I told you, that is the modular transfer function, which analyzes basically the contrast sensitivity. As you can see, the area under this curve is quite less. It is almost only 20%. So patient again had the complaint of decreased contrast sensitivity. It is because of this thing. And fourth, and the most important one, as I told you, the angle alpha and angle kappa values, they were quite high compared to what we would have liked. It should be less than 0.5, but here the angle alpha and kappa value was slightly borderline. So my patient had all four things: high external aberrations, poor point spread of functions, lesser area under the curve for the contrast sensitivity, and large angle kappa, and the relatively borderline angle alpha. So the take-home message is, it is not that just you are doing a good cataract surgery, you are putting the premium lenses, and you are going to get the results. You need to use the latest devices, which I feel is the wavefront aberrometer is the way to go ahead. So eye trace is one of the device, and it has definitely increased my confidence when I'm putting more and more premium lenses. I don't know how many of you has the eye trace, but that has definitely changed the way I put my premium IOLs. And after following this practice, I barely get the patients who complain of the glare or the halos or the decreased contrast sensitivity. I would like to see what is the DIA's view on the same.
I think you must have had a reason to exchange quite few lenses for unhappy
Yes,
patients also, because I
exactly.
think if you have the tool with you, you can
Yes.
pin the problem as well.
True.
Yeah.
Ultimately, I did exchange the case, and I put the eye hands, and I did it after around 1 month. I waited for around 1 month. Yes, sir. It was absolutely normal. No, sir. All my values became normal because nowadays Tracy has improved the software, and it also gives you the selection, IOL selection analysis, where it will guide me which type of lens I should put. So here it came, it was the monofocal, aspheric, and non-toric one. So that's what I tried to put it, and I just said patient as was demanding more of the computer user, and IHANS gives me good distance as well as intermediate, so I had gone for the IHANS. I just counseled the patient that I did not say that it is the doctor's mistake. I said many of the patients don't accommodate well, and as such, you are not happy with this. The best way to go is to put the monofocal IOL, which will take care of your distance vision. And once these patients, once they have seen these side effects, they usually get agree. And I think I have so far exchanged around 4 lenses, and that's why I learned it hard way. I had the Tracy, but it was just lying in a corner. So I decided to use it more and more, and after that, I'm very happy. Which one, sir?
Eye trace or other
Sir,
abrometers?
I'm
No,
using the
sir.
eye trace since so many
Actually,
years.
we are
So
working with so many companies, Sanjay sir, just to get the machine which can give the similar value and the readings, but still date not yet come. That is why they place the price around 40 lakhs rupees.
I think they'll give you in 30.
Hmm.
I think the biggest problem with the
Ahmedabad, no?
multifocal lenses
Rule
is when
India.
what he faced. Always say under promise, over deliver.
Deliver.
And counseling should be. There was a lecture by Dr. Harbanslal. He gave a very practical tip. He says we tell all multifocal patients that it sometimes it doesn't suit. If it doesn't suit you, we'll replace it without any cost.
Yeah.
So that saves you probably. No, he gave that statement in your this thing. So we can always. Pardon? नहीं नहीं डरेगा तो अब आपकी जान तो नहीं खाएगा.
So
This is one of the causes of violence against doctors also.
true.
And
So that is the reason you have to do it pre-op, and that's why these wavefront aberrometers play a
Yes.
crucial role, sir. And what I do, I show them their reports. See, this is how you are going
I
to
would
see.
say we should not do these procedures unless we have the best of equipment.
And other thing I want to say is that why, like we have customized power-based IOLs, we have different powers suiting for different patient. Why don't we have customized asphericity also incorporated into the lenses? I think that will take care of a lot of these functions where modular transfer function, contrast sensitivity will be taken care of.
I think
We
that
have only
the
minus
idea
0.27
of
or minus
I-
0.18. Why
idea-
don't we have customized asphericity incorporated
I
into
think
the
that
lenses?
for the last so many years, the idea of LAL, light adjustable lenses, that is coming up. They say this thing theoretically that everything can be, rectified
Just
with
adding
the
on
lens
to
inside the eye.
Dr.
But
Bala.
that is not, I think, practically not
Just
done.
adding on to your value, me and RC Shah from Mumbai, actually, we involved in one of the research product for getting this Q value lenses. Okay, depending on the Q value, there are different models of lens. So it's almost about to release into the market. But the final advisory board, one of the very senior surgeon from India, he did not like whatever the data RC Shah produced, and the whole research has been taken out. But I have done 100 lens for as a study part. At least 50% of the patient, these Q value lenses, they had a 6 by 4 vision, sir. Something amazing. I am really shocked to see how patient get. But you have to spend time with the patient. You have to see their aberrations before. then you have to order for that particular lens, then you implant.
Yeah,
Hey, that will be
very
wonderful.
good.